we can use this copy today. What is triage? Triage is simply, these objectives in triage that we must understand the nature of triage, describe where triage takes place, learn how triage is done, understand triage by sieve that as I told you last session, and secondary triage or the triage by sort. What is triage? The triage categories, triage tool. Triage, as I told you in last session, is a French term. French term, the first to implement triage was Napoleon Bonaparte on his war. That he has the injured soldiers to return it to the war as soon as possible to have so many numbers of soldiers, and he delayed the most injured soldiers to have the late chance as little improvement until Vietnam War. In military and civilian triage, there is a controversy. Sorry,
the presentation is not shared. If you are now presenting, it's not shared.
I can see it. I can see it.
Okay, so maybe I...
Okay.
Yeah, I can see it, yeah.
Now you can see?
Now it's a definition.
We are now in military,
okay.
yes, military versus civilian triage. The difference between military or civilian triage, okay? You can see it?
Yeah, I can see from my side.
Please, please, our colleagues, if you have any difficulties, please raise hand and ask us again to share anything you know and anything you want, okay? Let's go back to military versus civilian triage. The military versus civilian triage is the military is a priority to get many soldiers back into action as soon as possible. But the civilian triage is a priority to maximize the survival and the greatest number of victims. If we have a large number of victims, we must to minimize the loss and maximize the survivals from our disaster. Aim of triage, as we have no regress, as we told, and I told you in the next and the last presentation, to do the right patient in the right place in the right time, when there's the most important statement with no regress. As in disaster, we maybe have a lot of victims. The decision is only for you. Please do the right patient in the right place at the right time. When you have the wrong patient on wrong place, if patient is arresting on the outpatient clinic, you can't save this patient. So you have the right patient, the right place, the right time, that to equal no regress. Triage is a dynamic process. It happened first in the scene.
Sorry again, but some of the participants, they didn't see the slide. Can you stop sharing and share again?
Okay, I will.
Yeah, please. Thank you, Doctor.
Now, you see now?
It's coming.
I will wait a couple of minutes. If there is any problem, please tell us.
I can see now. Okay.
And I can see as well.
Okay. Any participant have any problem, please write to us. Okay.
Yeah.
Let's go.
Thank you.
To what is triage? Is a dynamic process. Triage is a dynamic process. We can do it in the scene first, where the first officer arrived to the scene. we do triage during evacuation, which is have the priority to evacuate first to the ambulance, to the hospital, to the ER area. Then we do triage also at the hospital before surgery, post-surgery, and every day till the disaster closed. Okay. The first time of triage, as we took the last session, is performed in the field by the ambulance officer who first arrive at the scene. The triage by SIEF is a priority to locate, triage, tag each casualty. This is the aim of triage by SIEF. At the scene, the first officer, always the ambulance officer, that's the first officer arrived to the place of evacuation or the disaster. So we can locate, triage, and tag each casualty with a triage card or a triage information tool. The goal is to spend only about 20 seconds on each one casualty. So it's important statements. Every statement have a goal. Only 20 seconds, as the triage by SIEF, as we discussed, have to be the right person in the right time. If we have a late, maybe the second casualty was in need for me and I will be late. Okay, the maximum time I spent less than 20 seconds in each one casualty. During the triage by SIEF, the only immediate life-saving treatment is very important also, is clearing the airway. No any medical step done in the disaster state in triage by SIEF. No treatment, no CPR, no other one to have less than 20 seconds. That is our safe to save more number of casualties. Less than 20 seconds, the only maneuver is clearing the airway or performing an airway maneuver only. No basic life support, no other life support to save the huge number or the biggest number or the max number of casualty safe. Triage by SIEF, please, if you have the last session, you must have this slide, or if you don't have this slide, please capture it or have a screenshot, as we will play soon. All of us will play an examples of casualties. If a triage of SIEF must have less than 20 seconds. If patient is walking, ask if you are the ambulance officer, ask the patients or the casualties. If you are walking, please go this side or this sign. If he is walking, in spite his other condition, this is a priority green, priority delayed for me. If he is walking, to give the priority green. If he isn't walking, please check the breathing. If he breathed, okay, he is surviving. If he doesn't breathe, please check the airway. This is the only maneuver in triage by SIEF. When we check the airway, if the patient respirated, is the priority immediate or red. If he didn't respirated, so this patient is died. Okay. Okay. If he is have a respiration, so we have check if respiratory rate 9 or less, 30 or more, this to priority 1 or immediate, as we have a red color. If the respiratory rate between 9 and 30 per minute, please check the capillary refilling time. If the capillary refilling time over 2 seconds, it will be immediate, as it reflected a hyperdynamic circulation or tachycardia or any great event. Okay, if the capillary filling time 2 seconds or under and the respiratory rate between 10 and 29, this is priority 2 or yellow or urgent. We must evacuate at first immediate or priority 1, then evacuate priority 2, then evacuate priority 3. Okay, it's a dynamic process. If I have now triage and I complete my casualties, then if a dynamic process priority 2 may be deteriorate to priority 1, and priority 1 may be go to the priority 2 or stabilize. Okay, so we can tell the triage is a dynamic process. This screen will use in next step. Please, I will let you to take a short screen or capture this slide. This is the area of triage. I told you when you have a green, please walking or wounded, walking is immediate care that have more and more equipment, monitor, oxygen, CPR, crash trolley, whatever. And this is a triage maybe change every time. This is the ideal entry of ER during disaster. Training, let's play. Let's play, please. This first patient, we will use Dr. Ahmed Hijazi will use name by order in our session. And if you want to ask anything, please raise hand and we will discuss with the participants that is in turn.
Okay. So case number 1.
Case number 1, who?
Yeah. So we have here in the first 2, we have Dr. Isra, Dr. Ghalia. So please, any one of you, let us focus and try to solve what
Dr.
triage
Isra, Dr.
category.
Ghalia?
Yes.
Okay, Dr. Isra, Dr. Ghalia, we can hear you now.
I will give allow to talk, so you can unmute and tell us what we can do for this. So we have, as Dr. Riham is showing here, if you can see the slide, patient states he can move.
We will read.
Yes,
we will read and explain the slide. But please, Dr. Isra, Dr. Ghalia, are you there? Unmute, please. You have muted your voice. If you can hear me.
Yeah. Okay. If you have an issue in your mic, you can just write in the chat, and we can see. Or if not, we can move to. We have also Dr. Hana. You can be with us, Dr. Hana. Dr. Hana disappeared. Yeah.
It's more easy. It's more easy.
Yeah.
Dr. Mona,
so I have Dr. Mona raised her hand.
Okay.
Okay.
Unmute, please, Dr. Mona.
Yeah, please.
Yes.
Welcome, Dr. Mona.
Welcome for you also.
Okay, this is a more simple case. Patient
this is. I think this is priority 3.
That is green, red, green,
green,
red, yellow.
Green.
Yes. Why?
Why? Because it is move. The first one, it is can move.
Yes. Yes.
The other thing is the respiratory air 26 is okay.
Okay.
And also the pulse is okay.
Okay, thank you. Okay.
Excellent, Dr. Mona. Thank you so much.
Thank you.
Thank you. Thank you.
Thank you.
Next casualty.
Yeah, I made something that can help all. So I give permission to all attendees to talk. So you can just unmute or raise your hand at any time. So all of you can talk at any time. Okay.
Okay, okay. Also, Dr. Mona, I'm here you, and you can share with me anytime. Okay, this is the second casualty, the patient lying on a stretcher, patients, gurgling sound, breathing, respiratory rate or respiratory rate is 6 per minute, capillary fill time 4 seconds. What is the priority, please? You can all share now. Please unmute. دكتور نور اتفضلي.
I believe this is priority number 1, immediate.
Why?
Because the respiration R6, it's actually
Below 9. Yes.
exactly, it's below 9, and the capillary refill over 20 seconds. It's 4 seconds. So
Okay.
that's move us to priority number 1.
Over 2 seconds, not 20. Over 2
Exactly.
seconds. Okay, thank you. Thank you. Thank you. This is
Great.
immediate. Okay. Next one, the patient lying on a stretcher, talking normally, has abdominal pain, respiration 24, capillary fill time 1 second. What is the category?
Okay. Any one of the attendees, you can unmute and answer or write in the chat.
Again, patient lying on a stretcher, talking normally, has abdominal pain, respiratory rate or 24, capillary fill time 1 second. What is the priority of this patient on triage by thief? It's more and more easy. Please share. The more difficult is becoming.
I believe from my opinion, I believe the answer is not difficult.
Okay. Let's play Dr. Ahmed.
Okay. Can I answer?
Okay, it's our pleasure.
Okay, I believe it's priority 2. Okay.
Why?
Why? Here the capillary fill, sorry, no.
Patient lying on a stretcher, not walking. Okay.
Yeah.
So we
so
have a
this,
priority 1 or 2. Priority 1 or 2. Okay.
yeah,
So
but
respiratory rate between 10 and 29,
which is good, yeah.
which is good. And the capillary fill time is under 2, which is priority
Good.
2 as you answer. Thank you, Dr. Ahmed.
Okay.
I think that is a great
Okay.
idea. Okay.
Okay.
These patients, please, I hope you all to share us. When we all share, you can discuss and to give the information clear. This patient lying on a stretcher, no response, respiratory 24, capillary fill time 3 seconds. 3 seconds. What is the priority if the patient have capillary fill time more than 2 seconds? No one have the answer? Okay, I will answer this. Lying on a stretcher, no, as he is not walking, respiratory rate between 20 and 29. Okay, but the capillary fill time more than 2, it is a priority 1. I hope I'm right. I hope
Yeah.
I am right.
Yeah, I believe so. Yeah. Okay. Priority 1.
Okay. Okay.
Good.
Let's move. Let's move the another one of this kind of triage, 45 years old male lying against the wall, unconscious, respiratory rate 0 despite airway opening. It's more easy. Why you aren't sharing, my colleagues? Why you aren't sharing? It's more and more easy.
Okay, you can
If you
see
have a
here.
difficulty in this information, please tell me.
I
Okay,
can
Dr.
see
Noor.
Dr. Noor. Yes,
Okay, you are
please.
welcome.
I believe he's dead.
Yes, because his respiratory rate is 0 despite opening the airway. Thank you, Dr. Noor.
You're welcome. Thank you.
Okay.
Thank you.
This patient walks over to you and has an obvious broken arm. Respiratory rate 22, pulse, radial pulse 124. He is awake, alert, and crying. What is the priority? I think you had a priority from the first word.
And the crying. Okay.
Let him cry. It's not our principle now.
Yeah.
But the patient at the first is walks. If he is
Okay.
walking, he is a delayed priority.
Yes. Yes.
Sorry, Dr. Mona. Let's go to the another one for you, Dr. Mona. I will be back another one for you. Dr. Mona, please unmute. You will answer this patient. 24 years old male, walking, have a burn of both upper limbs, respiratory rate 16, CRT 1 second. Dr. Mona, please unmute. You have a raise your hand, but you have mute.
So what do you think for the priority of this case?
I think the priority is
Mm-hmm.
is green. So the patient is walking.
He's walking. Yes. Yes.
Yes, yes. Okay, Dr. Mona, can you hear us? Let's go to the next or second type of triage. Triage by sort. It's
Okay.
more difficult and complicated. Let's remember that the triage by sieve done by first officer arrived at the scene, and it's a dynamic process at the scene, at the ambulance, at the ER, at the hospital, pre-hospital. It's a dynamic process, okay? But the triage by sort is more complicated as it performed by the senior paramedics, nurses, or doctor with pre-hospital triage training and triage gate prior to the entry. It will be a planned process. The planned process as it based on a calculation of the triage revised trauma score. Allows a refined triage priority. It refines the triage by sieve as we mentioned. This is the refining of this triage. Allows a consider anatomical neurological evidence that we discussed before. Triage by sieve, the only maneuver is opening airway, but here is different as we measure physiological parameters. At first, we calculate the Glasgow scale. Please capture or have a short screen of this screen as we will use in our game. If the patient has Glasgow scale depends on eye opening, verbal, and motor responses. If I open spontaneous, we will give 4. If the eye open to voice, we will give 3. If I open to pain, if we check the patient, please open your eye, and he responds, that will give 2 to the patient. If the patient can't respond or opening eye anymore despite painful stimulation, the patient will have 1. The verbal response, if patient oriented, place, time, name, what happened, is patient is oriented, we will give him 5. If patient confused, have one information, one right information and another wrong information, he is drowsy, he can't compensate our talking or our questions, patient will have 4. Inpatient inappropriate will have 3. Incomprehensive will have 2. No response will have 1. If the patients follow our commands, please raise your hand, please do your leg, please have to right, to left. This is follow our commands, we will give 6. If the patient localized pain, we will give 5. Withdrawal to the pain with 4. Flexion to the pain, we will give the patient 3. Extension to the pain, we'll give the patient 2. No response, we'll give 1. This maneuver with working is coming more and more easy. So we have in ER, I will spot the patient. This patient will have 3/15. This patient 4/15. This patient is 10/15 with experience. Okay, so we calculate the number from eye opening and the number from verbal response and the number of motor response. The number we will have, let's comma score A plus C from 12. 4 and 5 is 9. 9 and 6, sorry, 15. Okay.
15. Okay.
15. Sorry. 15. If the patient have 13 to 15, he will have 4 in class comma scale. 9 to 12, we will give the patient 3. 6 to 8, we will give the patient 2. 4 to 5, we will give the patient 1. 3, we will give the patient 3. Okay, please capture this slide also and have a shot screen for it and save it in your mobile. Next one.
Dr. Rihem, may I have a question here? So if we go to the previous slide and how we can deal with the pain like withdrawal, flexion, or extension practically.
If we have a pain, the patient can flex to have your arm out.
Okay.
If you have, he can't localize, we have a movement extension to the pain. Okay. Why? By experience, when I am on ER, I don't have this all exercise. When I saw the patient have 10/15. This patient is 12/15. It may, okay, a triage card, just we have enumerate and circle. We can calculate. There is no time calculation. The triage card, I will share soon after this slide, have to circle or checklist. To the end, we have to diagnose or triage your patient. Okay. Then we also calculate the respiratory rate. If the patient's respiratory rate from 4 to 29, we'll give the patient 4, more than 29, 3, 6 to 9, 2, 1 to 5, 1, 0. This is also a checklist. We have number and circle, the number and circle, the number and circle. Then we will calculate A, X, Y, Z. It's a triage score. The last item is a systolic blood pressure. More than 90, we will give 4, and to the end. Then we calculate the number here with the number here with the number here on our card. It is not more than 1 minute to have this calculation, not more than, as it's a checklist previously prepared. If at 12, the score is 12, this is a priority 3. 11, this is a priority 2. Less than 10 is a priority 1. 0, the patient is died. Okay, I will beg to please save and capture the glaucoma scale. We will use it in our game. We have 10 minutes to clear and end our session. Please capture this, and please capture the calculation of the triage sort score. Anyone needs help, needs any point to be clear, please raise your hand. And please capture the assignment of the triage priority according to glaucoma scale and the triage sort scale. Let's go to the first patient. Oh, please, all of you, I hope all of you to share.
All of you are allowed to talk and you can share.
Okay, please. Who can share with me the steps? Please raise your hand. Dr. Ahmed Hassan. Can you hear me? Dr. Mona Saudi, also you asked to join?
Yeah, I see Dr. Ahmed is already on mute, but we can't hear you, Dr. Ahmed. Okay, so
may I suggest something?
Okay.
Yes.
It's to overview back the scheme that you talked about. You put the case and then you go back and overview for a moment the previous slide, just to help them, I mean, recall back or retrieve back the case.
Okay, this is a different 3 slides, as I asked it to have a capture or short screen this, please.
I mean this one.
And we have many cases, yes.
I guess.
Okay, please capture it to be with your
and the another, I think the
one after,
XYZ, the XYZ scheme.
Okay.
Okay. I will share the 3 slides. Please capture this slide and save it in your device so we can have our game. And this is the last slide. If you have to be back, please ask us. Let's go. Let's share.
Okay, so if you already captured the slides, and so let us review this first case with Dr. Ariham.
Okay, this 26 years male, lying on face, okay, opening the fracture on right upper limb, complaint of abdominal pain, guarding left upper quadrant, respiratory rate is 32, systolic blood pressure 110, eye opening to voice, move spontaneous, patient is confused. Let's calculate glaucoma scale. Please, I want to calculate with me the glaucoma scale.
Okay. I know it's not an easy task.
Yes.
Yeah.
But it's amazing.
Yeah, but it's really important. So if we talk, for example, about eye opening, so eye open to voice.
Eye open to voice. It will have 3.
3,
okay?
Yes. And then verbal response. So he's confused.
Yes,
so
he will take 4. 3 and 4 equals 7.
7.
Okay. Motor.
motor, he is moving spontaneous. This is the one.
No.
I don't know which one I can, but I see that he has an abdominal pain.
Moving is spontaneous with it's a free motor. Free motor follows command is move walking or not walking as we asked it. He will take 6. 6 and 7 is 13.
So we are talking about 13 for Glasgow.
13 for Glasgow. XYZ 13 for Glasgow chart will have 4 points.
Okay, so 13 will give us 4.
Okay, respiratory rate is 32.
It's 32. It's a high. So I think here it's 3. Okay.
It will 3. 3 and 4 equal 7 till now. 7
And
till
then
now.
systolic is good.
Systolic is
4.
good. It will take
4.
4 and 7.
And 7, 11.
11. 11 in assignment triage priority is a
2.
priority 2. It's right. Okay.
Interesting.
Let's have the last one. Interesting, but it needs to be shared or played.
Yes, it needs the practice because, guys, if you are in a situation and you are trained well, you can react quickly. But if you are in a situation and you just hear this presentation, you will know that, yeah, there are triage, but I don't know what to do. Okay? So
Yes,
I suggest...
as I told you, doctor, with experience,
yes.
With experience, we have to mark it quickly.
Yes. So we took some time to make the first
let's
one.
go to this last patient.
Okay.
Okay.
So
Next
again,
one,
we will start with
let's
Glasgow,
try.
and then the
Yes.
triage XYZ. Okay.
Patient walking.
Walking
Okay.
is good.
So motor. Yes, motor will have a 6, and
Okay.
verbal response. Patient open eyes spontaneously. It will have a 4.
4.
Move spontaneously have a 6, as we mentioned.
And speaks
This patient
normally.
collected 10. Okay.
And the
We'll
5
have a
speaks
5.
normally. So it's 15, the highest one.
15 over 15. Yes. 15. We will collect 4 points in Glasgow
4.
scale. Then respiratory rate 14. 4 also.
So it's the
4
highest
and
one,
4.
which is 4. Yeah.
Yes. 4 and 4 equals 8 till now.
Blood pressure.
Systolic blood pressure 100 over 40. Sorry, 140.
So which is again 4. So we are talking 4, 4, 4.
Again.
So it's 12.
Okay.
So I believe it's good.
Okay. This patient 12. Priority 3. Okay. Let's go. This is a triage card, as we mentioned.
Okay.
Okay. This is the facilities that screens by triage, save and sort, as we mentioned, to save. Just checkbox and circling and folding. This is a folding card to triage your patient. This is the card in nature. When we fold, the patient is immediate, and this is what will be the neck of this patient or in his arm.
Okay, that's interesting.
Okay.
Yeah.
Okay. Summary The triage is the first step of truly medical support, as we told that in the first steps, we don't have a medical support. Even in triage by sieve, we also open the airway in less than 20 seconds. Triage is a dynamic process. Patient may change from priority 1 to priority 2 anytime and reverse. Triage by sieve is a primary and rapid assignment of priorities. Triage by sort is secondary and refines the priorities after triage by sieve. Triage tags or cards defined show the patient current priority. We can't deal with mass casualty, everyone with his name or with his covering or just by color.
Okay.
And thank you.
That's very good. Thank you so much, Dr. Riham. I really appreciate. There is a small question: how to measure to check for the capillary refill?
Capillary refill time, you will check the capillary refill time with your thumb and to be a pressure. Then hold. This is a physiology method. When you hold the pressure and give away your hand, your capillary or red line will be back. It will be back لسه more than 2 seconds. If less than more than 2 seconds, it means you have a hyperdynamic circulation. It means you have bleeding or you have shocked, you have lowering blood pressure, you have emergency.
Okay, very
so
good.
we have in the systemic aspect of circulation is a capillary filling time and the respiratory time. Both have the main function of the body that measure the respiration and the heart. If there were airway clothing or airway difficulties, whatever, as pneumothorax, hemothorax, whatever, we will slow the respiratory rate or the respiratory stress. It may be have a faster respiratory rate, and we will check the circulatory system for the bleeding, for choking. This is the way for obtaining this respiration and circulation.
Okay, so it's a quick and easy, or just click and pressure on any finger, mini thumb, yeah?
Mini thumb. This is have a mini capillary.
Mini thumb, yeah, okay.
Then, please take the time. This is well different from 1 to 1. You will feel it if you have checked this in a choked patient. So hyperdynamic circulation capillary will be more fast and fast.
Okay.
The normal is more than 2 seconds.
Okay.
Any question?
Okay. Very interesting. So I understood that having the Glasgow, so it's eye, verbal, and motor. So all will consider them as one item. And then the other 2 important items, which is the respiration and systolic blood pressure. So now we are talking about 3 items that will end up for 12. If it's 12, it's fine. When it's less, so it's giving priority.
It will provide all system checking in small time. Circulation, motor, sensory, eye opening, responding, all
everything,
on some small time. So we have to do fast the right patient to the right patient on a right time without regress.
Okay, so with an expert, how long it will take from an expert per patient to make this?
Not more than 3 to 5 minutes.
Okay, so we have first assessment that should be done in like 20 seconds, and then the second assessment, which will take few minutes. So this will ensure how we put the priorities, and then we'll deal and treat and manage the patients accordingly. Perfect.
Okay, I hope you have the experience. I know that is a difficult topic, and disaster medicine management, if you don't love it, you can't understand it. But if you have understand it, you will love it.
Yeah, because I believe that any healthcare professional, a physician, a pharmacist, a nurse, whoever is working in hospital, should be aware about at least these steps that can help in making the triage. So the experts will come and manage, and they know what they will do and how they can make the priority. So I believe it's important, even if there's an accident in front of you in the street and you are just passing by, so you will know how to help or how to tell people, guys, this is urgent, should be done now or immediate, or this is okay, this is delayed, so we can help
You will ask yourself
others.
at this moment,
Yes,
what is the priority?
yes.
You will remember me. You will remember me.
Yeah.
What is the priority? Please check airway, open the airway. Please, if you're
Yeah.
walking, go there. Please
Yeah.
have the capillary and respiratory. Okay, you will remember me.
Okay. It's emergency, and the actions should be very fast, guys. So we should be aware. So I believe having the few slides that Dr. Riham said, please take a screenshot or capture, and we probably can keep them on the mobile, put them in your favorites, in your photos or whatever, so you can refer back in case of any emergency that you can go back to them. Okay, perfect. Thank you so much, Dr. Riham. Any other questions, guys? You can use the chat or the Q&A or raise your hand, so you can get the permission to talk. Okay, I'm just checking the
Thank you,
chat.
all participants that interact with us. Dr. Mona,
Yeah.
Dr. Ahmed, Dr. Thank you.
Yeah. Thank you to all who actively participated. And we see here from Dr. Mona, thank you. It's very clear. So thank you, Dr. Mona. We really appreciate. And we appreciate answers from everyone. And we appreciate your presence. So it was really good to have all of you with us. And really thank you so much, Dr. Riham, for these two very interesting lectures. You uncovered the value and the importance of one of the very important topics that we might face at any time in our life, which is how to deal with the medical disasters, how to manage, how to understand, how to make the priority, and the triage, which is really, really very, very important. Thank you so much, Dr. Riham. We really appreciate, and we really appreciate having you with us.
Please,
Thank you
at
so
last,
much.
I have 1 minute. If we implement a triage on our COVID-19 disaster, we heard about the word triage. If the time is available, the word triage as some terms we have heard in media. If we play it, you must have the patient, old patient, a very old patient with cancer or with lung fibrosis or 1, 2, 3, 4 diabetic hypertensive with cerebrovascular stroke and pneumonia course type 5 needs a ventilator. And on other hand, we have 24 years old young man have a good health, but only have ventilator for COVID-19. And we have one ventilator. Which one? Which our priority? This is a triage that we heard about, the word triage. We will choose the youngest one. So this patient with cerebrovascular stroke have 80 or 85 years old with diabetes, hypertensive, stroke, unconscious, choked with in cardiac support, whatever, and a healthy young one with a pneumonia due to COVID-19. We will choose the young one. This is a priority in war triage with
War
COVID-19.
triage, yeah. So
Okay.
this is what Napoleon and the people who are
Yes.
doing the war making the priority. So I remember from your previous presentation that for the war you have to select because you don't have the opportunity to treat all, while the regular emergency you give all the focus to one
For
single
the one
patient
thing.
to
Yes.
maximize the chance
The most
to
worst by
yes.
schedule is the most worst.
Yes, the most worst. Okay, different perspectives, and I believe the people who are working also in the dilemma for medical bioethics, they should be have a lot of discussions on this. Yeah,
The rules now will give the doctor safe, as the only rule is yourself without
your
regrets.
own safety. Yeah.
Yes,
Okay.
yes. As the difference between this and this one is a declaring a disaster. When the general authority declaring disaster, you will be safe to let the worst to die or to be late for you. But if it's not declaring a disaster by the authority, you have a mistake to let the worst one.
Okay. It's really a dilemma. Okay, thank you so much, Dr. Riham. We really appreciate your
you.
lectures and your presentations. And thank you for all the participants for being here, and thank you for participation. And thank you so much for the panel also, Dr. Samir Fahmi, for your presence with us and your presence during the previous sessions. And I appreciate the great support from Cinfa. Thank you so much to Cinfa team and Dr. Mustafa. If you would like to have a closing remark.
Thank you, Dr. Ahmed, very much. Thank you, Dr. Riham.
Thank you.
The session is very interesting, although it's very difficult. I try to make something behind the scene, but it's not an easy. Maybe we need a lot of practicing.
Yes.
Anyway, no problem. On behalf of Cinfa, I would like to thank you really, and your contribution is highly appreciated. I think over 2 sessions, we learned a lot. And I hope you can continue with us the rest of the program as Dr. Samir. He's attending with us, and really your presence will be at high value. Second, I would like to thank Dr. Ahmed Higazi and Dr. Samir, and I would like to thank all the participants personally and on behalf of Cinfa, and I hope you can attend and participate more in the coming sessions, different topics. It is really it's an opening eyes sessions. I can say that. Thank you very much, and wish all of you a nice night, inshallah.
Inshallah. Thank you so much. See you next Wednesday for another topic. Finance for non-finance. I'm sure that it will be very interesting. Okay, thank you. Take care. Bye-bye.
Okay.